Andrew, how are you?
I'm good. Ken just came on. He may be giving you a call any minute. So it's ironic that you just got on. Because he asked me to try to share
sports health grand rounds. My name is Ken Johnson, Executive Director of the Ambulatory Rehab Therapy Services, and I'm very proud and pleased to present Dr. Andrew Koutnik to join us tonight to speak about his experiences and performance, nutrition, and research related to the glycemic index in athletes. Just a little bit on Dr. Koutnik. I had the privilege of meeting him through a good friend of mine who is aware of his work, and I'm so grateful to have had the opportunity to meet him, talk with him in preparation for this, and to learn more about his work and to share it with you tonight. But Dr. Koutnik is a research scientist at the Sansom Diabetes Research Institute, and he's a visiting scientist at the Florida Institute for Human and Machine Cognition, where he's running clinical trials investigating the impact of divergent nutrition interventions on cardiometabolic health in type 1 diabetes, prediabetes, type 2 diabetes, and obesity, that are all being currently funded by the American Diabetes Association, the NIH, and the Department of Defense, where directing medical research and program strategies. Previously, Dr. Koutnik conducted human trials evaluating the biologic impact of elevating ketone bodies under extreme stress in elite military and metabolically unhealthy clinical populations. And this was funded again by the DoD. But most importantly, Dr. Koutnik is a father, husband, type 1 diabetic, and type 1 diabetes patient who's advocating for those living with diabetes. And he's based in Santa Barbara, California. And most importantly, too, he's also an athlete. So with that, Dr. Koutnik, thank you so much for joining us this evening. I look forward to your presentation. Take it away.
I appreciate that, Dr. Johnson. It's an absolute pleasure to be here, guys. For those who are either watching it now or will be watching it later, I'm honored to be here and talk about a topic that's near and dear to my heart, which is the discussion of glycemic control and its relevance to various domains. So in this case, I'm going to touch on, and I assume everyone can see the slides. If you can't, speak up, but I'm going to go straight into, see if I can get everything started here. All right, can you guys see it okay? Can you give me a thumbs up if you see it?
Yep, slides are up. It looks great.
Perfect. All right, so the title of today's talk is The Implication of Glycemic Control on Health and Performance. And the reason I'm touching on both domains is I think it's important to understand why we would appreciate that it might even have an implication in performance. And that largely comes from the data in health. And again, already mentioned, research scientist here at Sansom Diabetes Research Institute, where the mission is to improve lives of patients living with diabetes, but currently work with and also have experience in working with high-level athletes or operational personnel in various domains where this was an important area of research. I do have disclosures, funding, patents, and also scientific advisory boards. So the table of contents. So what are we talking about here today? Well, I kind of put this as a roadmap, kind of with the analogy of sport, with the idea of first, let's say, checkpoint of the incidence of poor glycemic health. Looking at this from a definitions perspective, prevalence, risks, and complications associated with poor glycemic health, but ultimately diagnostic limitations and emergent tools that may help us overcome some of these limitations. And ultimately looking at something that I think is important to discuss from emergent research from our team and others on this undetected glycemia or dysglycemia that appears to be prevalent and well, I'll jump the gun. There appears to be some data that this may be happening in athletes. And number two, I'll pit stop along the way, is the impact of health and performance in the context of glycemia in athletes specifically. There's this idea of fit but unhealthy athletes, and what are the implications that glycemia has And there's a lot of emergent data in this space, and I touch on some key points in physical performance and cognitive performance. And then touching on some key lifestyle interventions that we can look at, both predictive factors that tell us what factors may move the needle in glycemia, but also tools and interventions that may be applicable and be applied in these domains. And ultimately some conclusions and take home, and then ultimately questions you guys might have. So first, let's define dysglycemia for anyone who's not aware. So when we talk about glycemic control, we're largely thinking about three key metrics, at least by definitions of how we define it, which is through something called hemoglobin A1C, fasting plasma glucose, and then oral glucose tolerance tests. Now, HbA1c is the amount of glucose that essentially sticks to red blood cells, and this appears to be a very reliable metric of around a 2 to 3 month average of glucose. So it's a long-term measure of glucose control, and really looks at total glucose exposure over that window. Now, we know diagnostically an A1C of at or higher than 5.7% is encroaching on prediabetes, not encroaching, but would be defined as prediabetes, and greater than 6.4% would then be diagnosed as full-fledged diabetes. For fasting plasma glucose, of course, this is just when you wake up, you're fasted, you go get a plasma blood collection, and you're just testing basal glucose levels. Again, anything at or above 100 milligrams per deciliter is diagnostic for prediabetes, not over the same number greater than or equal to 125 for diabetes. Or glucose tolerance test, more well known in the pregnancy space, but is an interaction between glucose and insulin, the dynamics of them. And this is, 75 grams of glucose. You test at multiple hour points post, and ultimately look to see, are you below 140 milligrams per deciliter? If not, you would be diagnosed with prediabetes or diabetes. Now, what is the prevalence of dysglycemia as defined by these metrics? Well, we know that diabetes, the prevalence of it, is one of the most common chronic conditions in the United States. There are various estimations as to the incidence or prevalence of diabetes, but I've just pulled some stats from the CDC from 2019 showing about 14.7%. You look at some more recent publications from high-impact journals, they're going to throw it around 11.3 to 11.7. But ultimately, this number is projected to triple from some recent publications from 2014 to 2060. And again, even the emergence of new therapeutic interventions don't seem to be slowing down this trajectory. There's clearly a train track that's on course to increase the incidence of this. And so obviously, we're looking to do something about that. But the problem is a little more complicated than that. When we look at the amount of diabetes that's prevalent, we also have to consider the amount that has been found to be undiagnosed. So there's quite a number of individuals who have diabetes who don't even know it. And the CDC estimates that around 23% if you only look at HbA1c and fasting plasma glucose. But in NHANES data, which includes A1C, fasting plasma glucose, or this dynamic interaction of glucose and insulin, the 2-hour postprandial oral glucose tolerance test, that number jumps up to about a third of individuals who don't even know they have diabetes, who do. And when you think about prediabetes and diabetes, the prevalence overall in the US. So before I say this, I also want to say a lot of people focused on metabolic health and look at the lens of overweight and obesity and say, wow, the vast majority of Americans are obviously struggling with these issues. And so 3/4 of Americans are diagnosed with something or at risk for something that would lead them to poor metabolic health. But it's always usually focused around weight. But looking at it from a glucose perspective or a dysglycemia perspective, if you consider all individuals in the United States, at least according to CDC and NHANES data from 2011 to 2014, that prevalence of prediabetes and diabetes both combined, so any form of at risk for or currently have diabetes, was 47.1%. But it's actually over the majority of individuals in the United States. If you only include adults, so greater than or equal to 20 years of age, it's 51.4%. So the vast majority, well, at least the majority of individuals in the United States actually have diabetes, prediabetes, or diabetes currently. Of major concern, though, is that 80% of people with prediabetes, according to the CDC, do not know they have it, who do have it. And that will lead into some other things we'll talk about here in a bit. So why would we even care about glycemic control? What impact could it possibly have that's worth caring about? What if I have a blood sugar of 100 versus 300? If it has no implications, why would we care? Well, the truth is that it has quite a robust implications. We know that when looking at just data from where dysglycemia is most prevalent, which is of course in the context of diabetes, there's a robust amount of literature showing clear implications for diabetes and its related complications. But central to this is glycemic control. It actually sits at the top. It's the king of risk factors with this disease as it relates to a number of downstream mechanisms of cellular change, immunologic reaction, and ultimately cellular death and or cellular dysfunction and death. So we know that glycemic control, both direct mechanistically and also through associative data and large epidemiological studies, show clear implications for overall health. So when we talk about, going from normal glycemia, which is defined as 70 to 120 milligrams per deciliter, to levels that are higher than that, or higher or more variable glucose values, we know that these have been linked to things like inflammation, advanced glycation end products, or AEGs, or AGEs, oxidative stress, epigenetic changes, and also shifts in osmolarity. So with higher glucose in the plasma compartment, more water will shift towards that. So you're changing quite a number of factors here by changing the level of glucose in the blood related to not just diabetes, but any gradient of glucose levels above normal. So what are the risks? Well, the risks are most clearly defined in the context of where we have the most data, which is in the context of type 1 and type 2 diabetes, which, and in these cases, we know that even elevations above normal glycemia or below normal glycemia, so hypoglycemia or hyperglycemia, are associated with acute physical and mental health symptoms, fatigue, irritability, loss of concentration, reduced cognition, where we also know more long-term elevations in glucose levels have been linked to, at least in diabetes, type 1 or type 2, full diagnosis, increased incidence of psychiatric disorder, stunted growth, cognitive decline, microvascular disease, macrovascular disease, increased risk for ultimate leading cause of death. And unfortunately, at the tip of all this is a shortened life expectancy of around 8 to 47 years. So this is quite clearly illustrating a number of things related to dysglycemia. And keep in mind, these are overlapping complications for type 1 and type 2 diabetes, whereas type 2, you have the other factors such as increased adiposity, elevated lipids, whereas in type 1, you're really focused on just elevated glucose levels and having to administer exogenous insulin, but most patients are actually not overweight compared to, at least not in excess weight like they are in type 2. But also there's data in prediabetes or undiagnosed dysglycemia, where we know that there's data that shows that in prediabetes, there's increased risk for all-cause mortality, increased risk for cardiovascular disease, microvascular disease, dementia, and cancer. So it isn't just people who are diagnosed with diabetes, but those who are diagnosed with early signs of dysglycemia, so elevated or more variable glucose levels than are normal. And this is just more data illustrating that anything above or to the right of that right line in the context of prediabetes is illustrating increase for one of the major causes of death, all-cause mortality at the top, cardiovascular disease, various forms of it, microvascular disease, cancer, and beyond. You can clearly see that almost always the studies from the World Health Organization, ADA, and beyond are illustrating increased risk. So it's not really a controversial topic. It's pretty well established that these risks exist. But when we talk about dysglycemia and actually detecting it through HbA1c, fasting plasma glucose, and oral glucose tolerance tests, there's some clear limitations to these. And there's a reason I'm bringing this up, of course, because I want to merge this for what is its relationship to health, ultimately to its emergence towards performance. is that when we talk about HbA1c, we know that, yes, it's a validated biomarker. It's the #1 risk factor in diabetes related to long-term complications, but it does have limitations. There's only about a 78% correlation to the actual glucose value, leaving a gap of around 22%, not explaining HbA1cs, at least when you relate it to things like mean glucose. And at the end of the day, we're worried about what is the actual glucose value. When talking about fasting plasma glucose, we know that it's only a very acute metric. You're taking this biomarker maybe once every 6 months or once a year if you're lucky in patients, and it's a single snapshot in one morning of their life of 365 days. It's one single snapshot of that. And it's also confounded by acute lifestyle factors, the physical activity the day before, the sleep, prior nutrition, and otherwise, which are the same issues that come up with oral glucose tolerance tests. These are only really valid in high carbohydrate diet environments. And we know that people are not just doing these diets, they're doing other forms of diets as well. And this brings up the obvious question, which is, we actually may have a higher prevalence of undetected or undiagnosed dysglycemia if we're only relying on metrics that have clear limitations revolving them. Again, if you remember one of the prior slides, if we only focus on HbA1c and fasting plasma glucose, where we had around a 24% incidence of diabetes diagnosis, and you include oral glucose tolerance test, this dynamic interaction between glucose and insulin, that incidence climbs to around a third. So obviously, how you look at this and how you're capturing this has clear implications for its prevalence. And this brings up something I'm sure many of you have heard about, which are continuous glucose monitoring devices. While these have come to somehow be controversial tools, they're remarkably amazing tools in the context of research or understanding the glycemic health of patients. Reason being is, if you look right here, bullet point 1 is that you get 96 to 288 times the glycemic resolution just in a 24-hour period. But over 2 months or even a full year, you're talking tens of thousands times the resolution on glycemic health. And how these tools work is they are essentially assessing a very close but yet indirect assessment of blood glucose, whereas blood glucose levels when you eat food or have elevations in glucose due to maybe some metabolic underlying health issue, they will ultimately reach the interstitial compartment and will eventually elevate glucose levels, or will be detected by the glucose sensor on the CGM, and that's been transmitted to, let's say, a phone or handheld device. And that's how these work. Very reliable tools, in fact, show that they're about a 90% or greater correlation to mean glucose values. Again, every single one of these sensors is typically around 7 to 10 days, depending on the company or the sensor technology. But it captures essentially everything: long-term glycemic control, dynamics between glucose and food and insulin over multiple days, just not a single snapshot. The obvious disadvantage to this tool is that it's much more expensive because it's much more new than traditional lab values would be. But either way, they provided a really advanced tool for understanding metabolic health, specifically with a focus on glycemia. And this then bridges the conversation to competitive athletes. We, along with some collaborators, Philip Prinz, Tim Noakes, and a few others, looked at a unique population of middle-aged athletes, highly trained. Okay, so body fat percentage around 15.7%. They were running around 50 kilometers per week. Their VO2 max put them in well above the 90th percentile. I think they were above the 95th percentile in this cohort. And the reason we were so interested to look at middle-aged athletes is because it's between this age of young and healthy and by definition, aged or older patients of greater than or equal to 65 years of age. We know that the incidence of diseases like dysglycemia and diabetes are much higher and when you're 65 years of age or higher, but we know that that is a process. We know that full-fledged diabetes actually begins with prediabetes, and we know it takes time for prediabetes to actually develop and ultimately mature into what is a much more harder diagnosis to reverse, which is obviously full-fledged diabetes. Hence why we are so interested in these athletes, looking at 2 dietary paradigms: a very low carbohydrate diet, sometimes called a ketogenic diet, and also a high carbohydrate diet, which is more of the standard of care or recommended approach by most institutional guidelines. looked at various metrics of performance, fat oxidation, glucose, and cardiometabolic outcomes. But one thing I want to focus on here is that when looking at these middle-aged athletes over a 31-day monitoring period, even though all these athletes were fit, all of them had incredible VO2s, all of them were exercising in incredibly high volumes, endurance exercise that is, 30% of them presented with prediabetes, either a mean, median, or fasting glucose value. And this was confirmed by only looking at the nocturnal fasted window in these subjects over a 31-day period. And you can see at the top two graphs there, whether you look at mean or median, that these subjects were sitting well within the prediabetes range. And that illustrates a concern. Are we seeing that athletes are actually presenting with prediabetes and they don't know it, even ones that are exercising? As exercise is one of the most powerful health tools we could possibly know of based on the evidence in the literature, but it appears that it's not making everyone immune to the potential incidence of pre-diabetes. So we actually followed up this work, and I'm going to present some unpublished data here, actually looking to see when we saw this incidence of around 30% in our cohort, we thought, is this a spurious finding, or is this something that's actually being observed in other analysis? So we actually ran a systematic search looking at articles of only athletes who were wearing CGMs over multiple days. So not a single snapshot of one time point, not just during exercise, but over multiple days to capture what was the glycemic control over time and their averages. And of the search criteria included, we only captured 10 studies that included athletes, and ultimately a much more refined cohort of only about 89 athletes from the total analysis. And when looking at this, you can actually see that this is plotting. Sorry, it was not 10 studies. It was a 5 analysis, 4 published and 1 unpublished, looking at this. And what you see is that across these analyses that actually showed CGM values, that over a 24-hour period, there was actually a lot of subjects who fell above the 100 milligram per deciliter line. Now, one of the criticisms of this would be, okay, well, that's 24 hours. You would expect some postprandial elevations in glucose that are completely physiologically normal in response to carbohydrates. But what we observed is that the association between 24-hour and fasting was tightly linked, and that when we just looked at fasting values, we see that there actually is around a 14% incidence across all studies ever published in athletes of what would be consistent with a pre-diabetes phenotype of a fasting level greater than 100 milligrams per deciliter. But again, I would argue that 24-hour is actually maybe a better representation, not just capturing when people aren't eating, although that's when diagnosis is most appropriate, is in the fasted window. But 24 hours is really a capture of the total interaction between glucose, insulin, and lifestyle. But nonetheless, we still see, if you only focus on fasting, that there is an incidence of athletes who are exercising at very high volumes and perceivably completely fit, having values that are higher than would be perceived as healthy and normal. And this then leads to this topic of what has already been published on since 2016 by Philip Maffetone and Paul Larson on this idea of the fit but unhealthy athlete. Now, what they postulated was this idea of this kind of no pain, no gain mentality that ultimately leads to high volumes of training, which can cause inflammation, oxidative stress, hormonal stress. And on the other end of the spectrum, this prescription often given to athletes to eat these very high glycemic, highly processed, refined foods, especially during actual exercise, ultimately leading to higher insulin levels and then potential incidence for inflammation, ultimately leading to this imbalance in metabolism, which ultimately leads to issues related to training, which makes athletes often not be healthy. When we think about the context of glucose, though, every single one of these circles highlights an area that glucose has data linking to it, direct impacts on the brain, impacts on glucose values being linked to overtraining status over time. Food is obviously directly linked with glucose values, inflammation, oxidative stress, and beyond. So let me kind of go into some of that data here when it relates to performance. So this is one paper, okay, not completely encompassing of all data, but here's just one paper from published in a very prestigious journal, Cell Metabolism, I think about 3 years ago, by Mikhail Flockhart and Philip Larson, colleagues of ours, looking at this idea of glucose control as it relates to athletes, or the idea of training. And what they did, which is a very unique design of this study, is they actually had two separate studies. One was a very refined in laboratory study, and one was an ecological study looking at national level competitors, cyclists, that is. And in this case, they studied cyclists, and they put these cyclists who were originally untrained through a high intensity training intervention. And not untrained, but they started at zero volume of HIIT while still engaging in their normal training program, and elevated their volume of HIIT throughout the entirety of the study rather robustly. And again, this wasn't, easy HIIT. They were really pushing it 5 by 4 minutes, trying to get around 95% of their VO2 max, essentially giving their volitional max over time within that 4-minute window. So this is not easy training. This is really pushing it training. And this was aggressive. They very specifically were trying to force overreaching, overtraining. Again, that's a whole different lecture I could give. But nonetheless, they were forcing a very aggressive, excessive training load on these subjects, and load progressing them way faster than would be typical. And they looked at various metrics of glycemia, mitochondrial health, and performance outcomes using this study design. Now, what did they find? Well, they found that actually excessive training had altered glycemic control. And this green line on the right-hand side illustrates the baseline value. So that's the 0 training time point for HIIT right here. Okay, and this is the green line right here, a normal glucose tolerance curve. Now, under the light training curve, which is the initial onset of HIIT, as be expected, exercise improves glycemic control. So they had a non-significant improvement in glycemic control. That's what you'd expect. Exercise improves metabolic health, all in line. However, when you get here to the excessive training load, where the load progressed into an excessive value, you actually see deterioration in glycemic control. And even when they reduced the excessive training load, it didn't completely recover, although began to recover. So it was a partial recovery of glycemic control. Now, obviously, by looking at area under the curve, there was a clear illustration of this, not just looking at the line graph of this excessive training load leading to a higher area under the curve of glucose. But what was interesting is that there was a link. They also did refined metrics of mitochondrial health, and there was a clear association between multiple metrics of mitochondrial function and this area under the curve of glucose, linking ultimately the dysglycemia related to chronic excessive training load, which can often be prevalent in athletes, ultimately with mitochondrial dysfunction. But why do we care about mitochondrial dysfunction if it doesn't matter? Well, it did matter, because that time point when they had this excessive training load was also when the athletes underwent a stagnation in the training program. They stagnated, as observed here. They progressed every week and then ultimately stagnated at the time point when dysglycemia was prevalent, ultimately linking poor glycemic health with this inability to progress through excessive training loads. And ultimately, when they reduced it, they saw an improvement in their training progression, but ultimately they stagnated at the time point when dysglycemia was prevalent. Ultimately, illustrating that overreaching decreased glucose tolerance in coordination with reduced mitochondrial function. And the second take home here is that exercise-induced glycemia alterations were linked to performance stagnation, and that partial recovery of that was observed once individuals removed this stress, which could be observed through a glucose viewpoint. But what about real world? These researchers also went on to look at what's the incidence of this, or is this even happening in the real world? Yes, we do a laboratory assessment. Yes, we see these unique changes in glycemic health in a really impressive study. But what about real world? And so they actually took national competitors, elite endurance athletes on a national team, and compared them to the general population that's exercising on a regular basis. So not sedentary individuals, but physically active individuals, but not training more than 7 hours per week. And then they look at continuous glucose monitoring. Again, this tool that might give us refined insight into a more dynamic interaction between the glucose health of individuals who are training. And what they saw is that individuals who are engaging in more excessive training load do see higher incidence of hyperglycemia, higher incidence of hypoglycemia, and reduced time in normal glucose range. Again, showing that there's this link between excessive training load, okay, this chronic stressor, and ultimately altering glycemic dynamics, which are detectable by continuous glucose monitoring and are linked to poor performance, at least in this study. But that's just a chronic assessment, right? And I must also say, I should have said this before I started going into performance data. Most of the data when we focus on dysglycemia has really looked at diabetes-related populations. Less has been looked at in the healthy population because it's always been assumed that these individuals were largely healthy. But in the incidence of emergent tools such as CGMs and otherwise, we've been able to really start looking at this differently and start capturing things that we weren't capturing before. So I'm really speaking to what has come out of that trend in research in this domain of glycemic and ultimately athletic performance. But that prior study was a chronic assessment looking over time in athletes. But in this study, they actually looked at a very unique human model. I'm a patient with type 1 diabetes, but type 1 diabetes is actually a very unique experimental model. In this case, they actually looked at insulin. And in type 1 diabetes, patients with my diagnosis do not have normal beta cell insulin or insulin producing beta cells. So when my blood glucose goes up, my beta cells aren't producing insulin to control it. So it gives total control over the insulin glucose dynamics if you use subjects and experiments with type 1 diabetes. And that's exactly what they did. They leveraged patients with type 1 diabetes, put them through a glucose insulin clamp protocol, and they did matched levels of insulin to control insulin variables within subject design. So they controlled the subject factors across both groups. And then ultimately put one group in normal glycemia, okay, 100 milligrams per deciliter, which is between 70 and 120. That's the normal range. And then put the other cohort at 165 milligrams per deciliter during the exercise, which was a 65% of VO2 max cycling effort. And what they found is that they were clearly able to induce elevated glucose levels. That was the design that was intended. But during exercise, when they induced hyperglycemia, they actually saw elevated lactate levels. And what this illustrated is that when looking deeper as to the rationale or the origin of this elevated glucose levels, is that it appeared that individuals in hyperglycemia had the inability to clear lactate as efficiently. And actually looking at the individual response data, almost every single participant, but one participant had a neutral response, had a clear reduction in the ability to clear lactate. Now, this was near ubiquitous, but the application or the implications of this is that we know that early onset of things like lactate threshold could clearly have potential deleterious effects on athletic capacity in an acute exercise bout. So this is also showing just an illustration of some of the data on chronic health in the prior studies, but also acute exercise implications on performance with what is someone's glucose values, in this case, during exercise. But what about beyond physical performance? What about some of the data on cognition or brain health? Well, this was a study looking at around 450,000 individuals in a UK database, looking at the association between glucose and ultimately brain health and cognition. And what they found in this data was that in individuals who had prediabetes, they had a 1% slower reaction time. And in those with diabetes, they had a 3% slower reaction time. Now, this may not look like large numbers to folks on this call. I think more than maybe anywhere else, the people on this call will appreciate the difference between first place and second place is usually less than 2%. So even a 1% difference in reaction time could be very meaningful. And I've worked with operational communities where 1% difference can mean life or death. So I would argue that this is not meaningless. And when going a bit further, they actually were looking at other assessments like MRI changes of things like hippocampal volume, of white matter volume. These have been associated with overall brain health. And what you see here is on the left-hand graph is a clear dose response in individuals who have prediabetes compared to low HbA1c, meaning normal, prediabetes, and ultimately full-fledged type 2 diabetes, a clear dose response for the incidence of worsening glycemic control and alterations in neuroanatomy, reducing hippocampal volume and ultimately increasing on the right-hand graph of white matter volume. So we know that alterations in glucose values are ultimately changing the neural anatomy of the brain, not just the function of the brain. And when we look at things like vascular dementia or all-cause dementia risk in the same analysis, we know that even prediabetes, and the reason I'm focusing on prediabetes is because of the data we've shown previously that even athletes who are exercising regularly, fit, have high VO2 maxes, are seeing values consistent with prediabetes. And we see that things like vascular dementia, all-cause dementia, the risk for this in patients with prediabetes is around 1.75 to 1.2 fold higher, regardless of the model they use in this analysis. Now, I want to make one little side note to type 1 diabetes. I'm not spending the vast majority of this presentation talking about type 1 diabetes, although I could definitely do that. That's just my personal bias here. We know that almost all the data in type 1 diabetes shows that elevated glucose values or very low glucose values deteriorate performance. That's actually where most of the data is in performance. The reason I don't show that is because I want to really focus on patients that didn't have diagnosis of full-fledged diabetes, because you're probably not having most of your patients walk through the door with a full-fledged diabetes diagnosis. At least based on the stats, that wouldn't be the case. But we do know that at least in type 1 diabetes, this is a perfect example of patients that are diagnosed with an autoimmune disease. They lose glycemic control. That's really the only difference they have from the general population. And because of that, they have elevated and variable glucose values. And the reason I'm showing this graph on the right-hand side is what it is children with type 1 diabetes, even within the first 4 years of their life, there is a clear dose response between patients with worsening glycemic control and worsening cognition and IQ. We also know that there's overwhelming evidence that patients in type 1 diabetes, once they have this elevation in dysglycemia, that there is blunted neurological development and changes in neural anatomy that are observed within childhood. So within usually the first few years of diagnosis in childhood, again, really illustrating how important glucose control is to health. Now, we focus on that on diabetes all the time and spend less time on prediabetes. But we should appreciate that this is accumulated impact over time, and hence why this is important to consider, even for athletes, because not all athletes are immune to dysglycemia. But that was an analysis in a large epidemiological study. This study actually looked at healthy subjects, or largely healthy, young adults, and looking at brain network stability, a metric of the function of the brain through MRI analysis. And what they did is they actually did a very unique experiment. And what I want you to focus on here is the top form of this experiment, is where they took individuals and put them through an overnight fast, so a very acute analysis. And what they did is they then provided just glucose, so something that we know rapidly elevates blood glucose values, and ultimately elevation in blood glucose in the serum is also elevating blood glucose in the brain. And we see this clear jump in brain network instability just by glucose alone, just by providing glucose alone, illustrating that a very acute elevation in glucose through the trigger of a glucose-based drink clearly has a very acute brain implications using very refined assessments. And these aren't in people with diabetes. These are young, healthy adults. But they then went on to study this over a 7-day window, looking at a standard diet, just overnight fast, or something called a ketogenic diet. And for those who are not familiar, this is typically a diet of less than 50 grams of carbohydrates per day. So the top intervention here is a standard high carb approach, typically at 45% or greater of the macronutrients from the diet coming from carbs, overnight fasting, or a diet that's largely depleted of carbohydrates, or not usually zero. And what you look over here is that when looking at this from a dietary perspective, over a 7-day window for each intervention, you see that the brain network instability is dramatically reduced, significantly that is, when reducing the amount of glycemic stimulus within the diet, in this case, carbohydrates. And that was also linked to analysis at the bottom here, where looking at cognitive function. So motor tasks, spatial navigation, at least in the short term and long term, you're seeing clear changes or differences between just standard diet approaches and overnight fasts and ketogenic diets, clearly illustrating that not just through an acute bolus of something like glucose, elevating glucose values in the serum and the brain, but also dietary interventions that manipulate glucose intake and ultimately glucose values in the blood also have implications on cognition as well. But even beyond that, we know that, from literature in type 1 and type 2 diabetes, that there's clear symptoms when you go outside of normal glycemia. These symptoms I've already alluded to are very commonplace in type 1 diabetes. This is actually a graph of someone with type 1 diabetes. And those symptoms, you can just go Google them in your free time, symptoms of hyperglycemia. These are mental and physical performance deteriorating symptoms, fatigue, blurred vision, disrupted concentration. Again, not something that would necessarily overwhelm your life, but in athletes who are performing and small differences matter, this is meaningful. And also the clear implications on hypoglycemia are very real, with shakiness, sweatiness, reduced acuity. The neuroglycopenic effect of hypoglycemia is a very real thing and is very clearly implicated on performance. But what are the predictors? So we talked about all this data on, poor glycemic health and, where it's most prevalent or we best appreciate, which is in the context of diabetes and what that tells us. But then we look outside of just diabetes and incidences of things like pre-diabetes, which we know even athletes are not immune to that, and what is going on there. But even outside of just pre-diabetes, just in normal healthy individuals, the implications of higher, more variable glucose values and what those could have. But what can we do about that? If it is having performance implications, if it does have impacts on even athletes, what can we do to improve that? And so we actually took an analysis of the data we took from athletes. So these are just athletes' continuous glucose monitors over a 24-hour period, first fasting values, and we looked at key predictors in athletes for what actually predicts elevated fasting glucose values. And interestingly, to my surprise, BMI was not one of the predictors. It did not seem to predict whether someone had higher interstitial fasting glucose values or higher and more variable glucose values. The reason for this potentially is that most athletes are usually lean and have high muscle mass. So even someone in the 26, 27 range, and I would fall into that category, and would not by any means be obese. Very rarely would that be the case, right? In athletes who's at a high performing level. Again, body fat also was not predictive of it. And fat-free mass was also not predictive of these glucose values. So again, body composition didn't seem to be what is predicting dysglycemia in athletes, or what is maybe giving us indication of what's happening in this unique population who should be immune to dysglycemia, but does not appear to be. And the only two predictors from all the data, I'm not showing you all the data here. We looked at VO2 max and other metrics. The only two predictors that came out of it was one, age. Age seemed to predict around 11% of the effect of on fasting interstitial glucose. So as you become older and older, there seems to be a clear relationship with not a deterioration, but a slight worsening in glycemic control, which is very consistent with the data outside of athletic populations. But actually the strongest predictor out of all of it was actually the carbohydrate intake of these athletes, which accounted for around 30% of the predicted impact of carbohydrates on, or of any factors impact on fasting interstitial glucose. So it seemed like lifestyle variables, such as nutritional factors in the context of carbohydrates in this case, was actually the largest predictor. And keep in mind, this is carbohydrate intake impact on fasting interstitial glucose. This is not carbohydrates impact over a 24-hour window where we know we'll have postprandial spikes that are largely physiologically normal. At least that's how it is perceived currently in the metabolic health space. This is fasting, which means that what you eat during the day appears to predict or change interstitial values in athletes during fasted windows. And this is also consistent with other data. So this is a data set of over 7,000 individuals in Europe actually using continuous glucose monitoring devices. And what they found is that actually a decent number of subjects, both male and female, fell into this category of having elevated glucose values consistent with prediabetes that, again, did not know it. Based on traditional lab values, wouldn't fall into that category, but using CGM values did. And again, this accounted for around 10 to 20% of the general population at 40 to 70% or 75 years of age, which traditional lab values would not capture, but a CGM did. And when looking at predictive values in this very, very large data set, not just athletes, but the general population, again, these yellow lines anywhere to the left or to the right is an illustration of impact of carbohydrates as a nutritional variable on these metrics of glycemic control. And it's very clear that the yellow line very much distinguishes itself from the other lines, which are things like lipids and proteins and total calories. It's very clear that carbohydrates were the most potent impact from a nutritional standpoint on glycemic control and normal, quote, healthy individuals without diabetes. So that then leads to this idea of what if athletes were to lower carbohydrate intake? Would this be potentially efficacious or effective at improving dysglycemia? And that's actually exactly what we studied. We actually took athletes and put them on a month-long, 4-week, very low carbohydrate diet or a very high carbohydrate diet. Again, staying with the standard of care protocol, which is recommended for athletes and for what they should do to maintain performance. We controlled body composition. We controlled volume of exercise. We controlled compliance. We did a lot of controls in the study to just isolate out, if you change carbohydrates, are you actually able to change glucose values? And what we saw is that basically from the onset of the diet, you see an improvement in glycemic control in athletes. Okay, so high level, highly trained athletes, once you put them on a lower carbohydrate-based diet, and improvements near ubiquitously in glycemic control. There was only one neutral response in mean and 2 neutral responses in glucose, but near ubiquitously an improvement in glycemic control by reducing carbohydrates impact by reducing it from the diet. Now, when looking at variables like time and range, standard deviation, coefficient of variance, max and min glucose values, it's a very consistent story, okay? Almost everyone responded by improving glycemic control by reducing carbohydrates from the diet, and these are in athletes. And it's also important to acknowledge that when people think about lower carbohydrate diets, they think, oh, well, those are associated with reduced performance. Actually, this is unfortunately a more controversial topic than it probably needs to be. But when you actually look at studies where someone habituates to a low carbohydrate diet, at least 4 weeks in duration or longer, you see that there's no real meaningful differences in overarching performance when going on these low carbohydrate diets. Most of the literature that's showing a deterioration in performance on lower carbohydrate diets is 3 weeks or less in time, while the adaptation to the diet is still taking place. And we know that because there's been multiple analysis showing that when someone lowers carbohydrate intake, it takes up to 3 weeks or more to see many of the major changes associated with the diet to fully manifest. Although some of those changes do last longer than that. But nonetheless, it is important to say to those in this audience that performance was not deteriorated. In fact, there was only a 0.7% improvement with low carbohydrate-based diets compared to high carbohydrate-based diets when we did very anaerobic-based exercise, or at least comparative to long-duration exercise. So this was actually, we did a 1 mile time trial, and we also did 6 by 800 meter split sprint. So really max effort, short duration exercise, and even the short duration max effort exercise, which is very glycolytic in nature, did not see deteriorations in performance with very low carbohydrate based diets. So again, reducing carbohydrate intake improved glycemic control in athletes, resolving the prediabetes in the 30% that actually had prediabetes glycemic values. And this was without negatively impacting performance. But we know that when we talk about low carbohydrate diets, one of the common things that's always brought up is compliance. We know that these effects occur when you low carbohydrates in the diet, but will people follow the diet? Well, this is a known issue with all diets. And that brings up, is there alternative strategies to consider that don't require someone to maybe go do a wholesale lifestyle change that they may not be applicable to? And this brings up this kind of interesting topic called of a nutrient called allulose. It's more of an emergent tool that I think was very interesting to bring your attention to. And what is allulose? This is actually a very unique molecule. If you look at fructose, and you compare allulose to fructose, this is actually what they call a C3 epimer, where you essentially flip the OH group. And by flipping the OH group, you turn a very calorically dense molecule into a 0-calorie natural sugar. So it actually is found in things like fruits. And so it's a naturally forming molecule. It is FDA approved, is generally recognized as safe. So again, something that people can do and buy over the counter right now. But actually, what's interesting is it's by no means inert. It appears that when you co-administer things like, or if you co-administer allulose with things like sucrose, and do this, what you could show here on the right-hand side, which is basically an oral glucose tolerance test with sucrose, and you just add allulose on top of it, you see this impressive blunting of glucose, and also not just glucose, but also insulin effects down here. Now, this is not the only report showing this. There's actually been a number of human studies showing this in various groups. So this is a very interesting molecule because it is a sweet flavor. It's 0-calorie, or largely 0-calorie, but appears to actually have some potential metabolic health benefits. And actually, when we think about performance, there hasn't been any performance analysis of allulose, but there have been some preclinical models that have shown the ability to potentially improve exercise duration and also improve muscle glycogen synthesis through some very interesting potential mechanisms that haven't been fully elucidated yet. But there's a lot of interesting data in rodents alluding to the idea that there's some pleiotropic or widespread impacts of allulose on metabolism that extend well beyond just the lowering of glucose and lowering of insulin. And this actually brings up some emergent data that we collected in patients with type 1 diabetes, where we administered allulose or controls prior to a typical carbohydrate or stimulus of glucose within the diet. And what you see here is one patient observation. I'll show you an example of an N of 4. So this is just pilot preliminary data of an emergent area and topic. But when provided the typical meal, this is a CGM graph linked to an insulin. All these blue bars are insulin. So in type 1 diabetes, you can actually capture insulin and glucose simultaneously. And when you provide this meal, you see this elevation in glucose, which comes down over time, over a 2-hour period. And you see this, robust effort by the automated insulin delivery system to pump out as much insulin as possible. But this is allulose over here. And what you see is about a 2.5-fold reduction in the amount of insulin required to handle this glycemic challenge, and also a stabilization of glucose simultaneously, which is kind of virtually unheard of in type 1 diabetes postprandial. And we also saw a a ubiquitous impact on lowering insulin requirements around 300% in these patients. Again, illustrating an emergent tool that seems to be quite promising based on prior evidence and this emergent evidence in the context of type 1 diabetes, where you can really control glycemia and insulin. So with all that said, I know I'm kind of over the typical time, but just to say in conclusion, dysglycemia is prevalent in over 50% of the population, at least here in the United States, according to CDC NHANES data. And even extremely fit and active individuals are showing signs and indices of subclinical disease manifestation without any known risk factors. And dysglycemia has data to show it impairs physical and cognitive performance, even as little as 1%, and sometimes much higher than that, depending on how much dysglycemia is prevalent, how high and variable the glucose values are. And higher carbohydrate intake seems to be one of the predictors of that in athletes. It appears that reducing carbohydrate intake can be a way to mitigate dysglycemia without negatively impacting performance, at least if you habituate to that lifestyle over time. And that allulose is an emergent tool that may mitigate dysglycemia, at least, but also has potential impacts on improving performance, at least from a preclinical perspective. So with that, just want to thank the CNSM Diabetes Research Team, the collaborators on the left-hand side, the funding sources. And with that, I'll stop sharing. I don't know how much time we have for questions, but I can stay on for a bit and answer any questions that people may have.
Well, Dr. Koutnik, it certainly was extremely well articulated, really, really well done, great research. When you think about sort of the two extremes of athleticism and intensity, I think about sort of amateur wrestlers, right? In fact, Dr. Dennis and I, and you were chatting about Division III sports, right? So that's 8 hardcore minutes. And then on the other end, we have the Olympics coming up with Katie Ledecky, right? The all-time superstar with 1,500 meters. Where and how would you shape a diet based on this thesis to both of those extremes?
Well, that's a loaded question, because then you're talking about a number of factors related to their individual metabolic response. Does this person, let's say Ledecky in this case, or anyone in this example, do they have signs of dysglycemia? And one would assume, most athletes are going to be largely protected for that, but not ubiquitously. At least our data and others have shown that. That's a very sport by sport situation, and honestly, individual by individual situation. One of the biggest problems we have is that we know that these it usually requires some, advanced laboratory tests for someone to find out this is happening, and so one of the safeguards some people may interpret what I'm saying as, well, then let's just improve glycemic control across the board. I don't think that's such a bad idea, actually, depending on whether the athlete is able to maintain their performance or improve it. In these cases, I mean, we're talking meaningful measures within the context of elite performance, about moving the needle even a little bit can make a big difference. So that's a loaded question. I can't give like the most, it'd be case by case. It'd be case by case, sport by sport, and individual by individual on how they may respond to that. But ultimately, I do think that being aware of your glycemic control and doing things to mitigate unnecessary glycemic excursions and controlling glucose health is important, especially over time. That data is very clear.
Outstanding. I would think in Colorado Springs, right, the epicenter for most of the U.S. Olympic type training, that the CGM might be something that they adopt like more and more.
So CGMs are unfortunately very controversial right now. A lot of people think, okay, why put a CGM on someone who's already healthy? The problem is that they're ignoring, well, at least some of this I present to you guys is unpublished. So they're unaware maybe of some of the emergent data saying that not everyone is so protected as we once thought. There's also an argument from people who have seen some of this data who say, well, they're athletes, they're largely protected. What does it matter if they're 100 versus 110 or 115? But that's not actually the question. The question is, are they developing a disease manifestation or poor metabolic health that is leading a 10 to 15 milligrams per deciliter elevation beyond normal? And that's really what we're discussing here. We're discussing is there a metabolic shift that is occurring that is being indicated through these more advanced metrics that a lot of people don't have access to? But athletes are actually some of the first to kind of jump on and try and get a hold of these devices to understand what is going on with them. And not just from a metabolic health perspective, actually, most of these people are looking at it because they want to look within sport, from fueling perspective, the idea of, reducing the bonk or not hitting the wall, and when can you refuel and other things like that.
Thank you.
As you're consulting with athletes, how do you distill down, sort of obviously the education, which was amazing, technical knowledge. How do you simplify it so that it's, no pun intended, to be digestible to them?
Well,
Like
I'll acknowledge.
how do you get them to understand why it matters, you know?
Yeah, that's a great question. Let me just say that I make zero money off CGMs. So this is my personal opinion alone. It's a lot of times what happens is when an athlete gets a hold of a device like this and they test it, one thing that is commonly, engaged, you ask them the question, how can you relate this value to anything meaningful in your performance or how you feel? Because that, I think, provides an important connection between something that people are largely blind to, which is their internal metabolic health at this metric, and other variables, such as performance, how they feel physically and mentally. And that's one tool if they can get a hold of that. The other end of the spectrum is there's a lot of mixed messaging out there on glucose values, what's optimal, what's not optimal. At the end of the day, it's very simple that 70 to 120 is the normal range. And that if you eat carbohydrates and you can metabolize them appropriately, it's great. It seems like there's a growing number of individuals who are having harder in time with that in our population. But nonetheless, with that said, it's important to appreciate that we want to maintain normal metabolic and glycemic health. That is cornerstone to long-term health. And so just understanding that the less we have to kind of stress that system, the better it may be. But unfortunately, with me just saying that, I could think of 100 reasons why someone may say, well, no, that's not, but what about this and what about that? But when you talk about distilling it down for someone to understand, that's one message that may resonate with some individuals. But it's hard because the typical prescription for performance is very high carbohydrate based diets, and stimulating those even during performance to maintain performance. And we even have data on that, looking at low and high carb, which will come out soon, looking at fueling intermittently. And obviously, we know those fueling strategies work. The thing is finding out what works for the individual's metabolic health while reducing the long-term implications that some of these things may have on metabolic dysfunction is really a key balance that I'm going to be honest, I don't think we've really struck our complete understanding as a field on how to do that. So it's really a practitioner who's willing to take an advanced effort on trying to help them navigate metabolic health. Because you could just, prescribe a ketogenic diet, right? Like those are one of those powerful ways to control this. But that comes with a whole can of worms that needs to be unpacked for an athlete about how to, or whether they even should do that. So.
That's great. Thank you. I think there was a question from Lindsay in the chat.
So, Lindsay, so the evidence right now says that you don't see major improvements in glycemia until you get to this low carbohydrate diet range, which is typically less than 130 grams per day or less than 25% of total calories in the diet from carbohydrates. There's plenty of studies that say that once you get low carbohydrate, and let me distinguish that from very low carbohydrate. Ketogenic is typically less than 50 grams per day. And then there's data on low carbohydrate, which is about 50 to 130 grams per day, assuming you're on a 2000 kcal diet, which is an assumption in athletes because they typically eat more calories, but just some context. Low carbohydrate is typically what is most commonly shown to have benefits. Above that is moderate carbohydrate range, and where you're starting to encroach actually on more of a Western diet, which could be of concern related to glycemic control, or as we appreciate it more in the research realm, is more of an obesogenic based macronutrient range. Not always associated with obesity by any means, but where we typically see higher incidence of metabolic disease is in that moderate carbohydrate range. So somewhere between 25 to 45% of total calories from carbohydrates.
I had a question, Dr. Koutnik. I think I understand, I would say, for the general population in terms of potentially providing more of a, I would say, a stabilizing effect. I'm also a fellow athlete. I do mostly endurance events, so marathon or beyond. Obviously, keeping your blood glucose kind of in range, throughout that with fueling is really challenging. Specifically the sweet spot, because lactate can be used as a fuel source. So I think a lot of athletes, especially at the high end, do have this kind of band that you would love to try and kind of keep yourself in. So it sounds like potentially allulose could maybe play a role in helping to, I would say, stabilize. Obviously, it's individual per athlete. Is that a fair summary of a potential, at least at the high end, to able to keep you within that kind of sweet spot zone for longer or in an easier way?
It's certainly possible. And from a performance perspective, it would be great to have those kind of studies and human performance perspective. But yeah, the thing from a long duration sport, like within exercise itself, okay, there's some literature, just the stimulation of carbohydrates, even by swishing it in your mouth and not even ingesting it, has a performance benefit, right? So there's a lot to unpack there as far as like what from carbohydrates is actually leading to performance. We have a publication, I'm actually working on the data right now, that will allude to this idea of, I'll just kind of jump the gun and say, we know that there's plenty of evidence that low versus high carbohydrate, if you habituate to the diet long enough, it doesn't matter if you're short duration, aerobic or anaerobic, you see pretty much near ubiquitous performance outcomes. We also have data that says that if you fuel during even a low carbohydrate diet or a high carbohydrate diet, it does help with performance, potentially through maintaining normal glycemia by preventing the hitting the wall or the hypoglycemia, which is discovered all the way back to 1924 in JAMA by Levine and I think Gutter, showing the first incidence of hypoglycemia during marathon runs in athletes. And so we know that refueling during long duration exercise, just by default, you have to potentially do that, period. And that counteracting that can be beneficial. How allulose can help with that, I think, is more so on the high end of mitigating some of the consequences of higher carbohydrate ingestion over time. Its implication in performance is something that'd be very intriguing to understand. At least in the rodent models, it looks like there's some emergent evidence which is supportive. So more to come.
Thank you.
Well, there's no more questions. I appreciate it, guys. Appreciate the time to be here with you guys. If you ever have questions, you can always reach out to me. First initials A and last name is Koutnik, Koutnik @sansum.org. And if you have any follow-on questions you want to ask here or have things that come to mind later, please reach out.
Andrew, thank you so much.
Hey, absolutely, guys. It was an honor.
Very
Thank you,
well
Andrew.
done.